and needs to be clear to everyone, to all residents, to all graduates in imaging. And first thing, the child is not a small adult. It's very important things. And the disease may differ from pediatric age group to adult age group. And this also may result in different therapeutic techniques and also altered imaging approaches. And the number one difference in pediatric imaging is radiation safety and radiation protection. Why is that? Because children are very sensitive to ionizing radiation, and they have growing tissues which are immature and extremely sensitive to radiation. And there is no minimum safety dosage that is considered absolutely harmless. And most importantly, the red bone marrow and the other tissue in growth, especially the thyroid, at this age group are very sensitive to radiation. Because of smaller body size and the gonads are so close to the radiated zones, it's very important to shield the pediatrics during the examination, and also to take in mind the longer life expectancy in children and the accumulative dose of natural and artificial radiation mean higher dose exposure to the pediatric age group. And they are more prone to develop malignant disease related to radiation overdose. And the best protection is to minimize or to completely avoid the use of ionizing radiation in children. And on the other hand, we have to have very strict control and supervision of the indication of X-rays and CT examinations. And we have to maximize the usage of non-ionizing radiation like ultrasound and MRI as much as we can. CT examination should only be performed if they are absolutely necessary, and if so, with the use of special and low-dose protocols. The so-called ALARA acronym stands for as low as reasonably achievable dose, which means that one should use the lowest dosage of radiation possible, and this point of view can never be neglected in pediatric radiology. So we're going to start by trying to tackle the most important daily imaging that done in pediatric radiology section, starting from top to feet. So the most importantly is the cranial ultrasounds that is commonly used as a bedside examination in ICU. And it's the first method of choice in brain parenchyma examinations. And it's readily available, no radiation, no harm, can be done bedside without moving a sick baby to the radiology department. And it's very valuable to have initial screening and evaluation of intracranial abnormalities. And it can be used up to 8 to 10 months because of opening of the fontanelle. Vertebral ultrasound also is another useful tool to study any patients with suspected spinal cord abnormalities or anomalies, like patients with tethered cord or sacral dimple, to evaluate for presence of deep sinus. And it can be done up to 2 to 3 months of life until the closure of the posterior arch or the vertebral arch with a linear transducer. It's very capable of diagnosing and following up cerebral complications of premature infants like germinal matrix hemorrhage, BVL, hydrocephalus, and also for screening of certain developmental disorders like corpus callosum agenesis, vein of Galen aneurysm, Dandy-Walker syndrome. So this is a normal head ultrasound. We usually do serial cranial cuts and or imagings followed by sagittal starting from midline to the right side until we reach the cortex and the vice versa on the left side, then doing trans-temporal or trans-occipital approach for posterior fossa. So in normal neonates on full term, you have well-formed gyri, and the sulci will appear slightly echogenic because of the leptomeninges. The lateral ventricles will appear like semilunar appearance. We accept minimal periventricular echogenicity in neonates, but it shouldn't be more than the adjacent corpus callosum, the adjacent choroidal plexuses. Also, you need to evaluate the corpus callosum, the parts of the corpus callosum. There is no agenesis or dysgenesis or partial agenesis of the corpus callosum. Very important to see the genu, the splenium, the body of the corpus callosum. Also, the thalami is very important to evaluate, superior sagittal sinus. All these are readily available by imaging ultrasounds and can be fully evaluated by the brain ultrasound. One of the most common pathology that encountered, especially in premature babies, are the germinal matrix hemorrhage. And the blood supply here is very rich, and because of fast growing, especially in preterm baby, it may subject to rupture, and you have what's called germinal matrix hemorrhage, or previously or known as IVH, or intraventricular hemorrhage. However, germinal matrix hemorrhage is the correct terminology to be used, as it describes exactly what's going on. And as you can see here on autopsy, there is bilateral hemorrhage in the caudothalamic groove or in the germinal matrix area. It may extend into the ventricle. That's why it has been graded, and based on the grading, prognostic values have been provided. So this is the germinal matrix hemorrhage grading, and this shows you the normal germinal matrix area, which lies at the caudothalamic groove, lateral ventricles, brain parenchyma. Grade 1, usually the hemorrhage is confined to the germinal matrix, while in grade 2, it extends into the ventricular lumen, and shouldn't be more than 50% of the volume of the lateral ventricles. If there is associated intraventricular dilatation, or there is extension of more than 50% of the volume of the lateral ventricle, then we consider this one as grade 3. Grade 4 is considered as intraparenchymal extension of the bleeding. However, nowadays, it has been recognized that it's not an extension, rather than a hemorrhagic venous infarction because of compression of the draining veins. Small draining veins here from the parenchyma usually drains to the germinal matrix. When there is a hemorrhage here, these veins will get congested and you will rupture, resulting in hemorrhagic venous infarction, and that's called grade 4. One of the complications of germinal matrix hemorrhage is hydrocephalus, and can be frequent complications, but about half of the cases resolve spontaneously. And the ultrasound examination is a method of diagnostic value, and also for a follow-up. We may rarely need a CT scan on discretion of the neurosurgeon if you want it, but ultrasound can give you the size of the dilated ventricles, whether there is a ballooning or not, whether there is a obstructive hydrocephalus or not. So it's very useful tool, avoiding radiation. And also it evaluates for whether the hydrocephalus is progressive or stable or regressing. So it's very important to have a follow-up with ultrasound and to limit the usage of cross-sectional imaging, especially CT scan. Another entity that has been seen frequently in preterm baby is BVL, or periventricular leukomalacia. and it's usually bilateral and results from watershed infarctions at the junction between the gray-white matter at the periventricular region, and usually starts with a very echogenic area by ultrasounds. With follow-up, usually it degrades into multiple cysts, and based on severity and extension, it has been graded, although it's not commonly used. So this is the grading of BVL. Grade 1 usually only increased periventricular echogenicity without any cyst formation persisting for more than 7 days. Grade 2, the echogenicity usually resolve into small periventricular cyst. Grade 3, when these cysts increase in size and extends to the occipital and frontoparietal region, while grade 4, when it extends to the subcortical region. So moving from brain down to the neck and trying to evaluate the pathology and the common pathology that's seen in pediatric neck. When we talk about pediatric neck, it's all about the air and air columns. If we master the air columns, we know how it looks normally, and that we know the normal appearance, then we can identify the pathology very easily. So this is the normal lateral soft tissue neck X-ray in toddler patients. If we evaluate it from above, this is the nasopharyngeal airway. This is the adenoid. It's slightly, enlarged, but there is no significant compromise. And this is the oropharyngeal airway. Then, most importantly, we have to check the perivertebral soft tissue thickness. It's very important to evaluate for presence of perivertebral soft tissue abscess, hematoma in patients after trauma. It's very important to check the perivertebral soft tissue thickness. And in the upper 3 cervical vertebrae, the width shouldn't be more than the half of the AB diameter of the vertebral body. So it shouldn't be more than the half of the AB diameter of the vertebral body, while from C3 down to C7, we accept up to the full AB diameter of the cervical vertebral body, as you can see here from these diagrammatic representations. Very important to check the epiglottis, the size of the epiglottis, the soft palate, the supraglottic airway, the infraglottic airway, that there is no stenosis here in the infraglottic airway. That's very important also to identify the mandible, the shape of the mandible.